Medurstand Understanding Medicine.
I'm Professor Aziz Rehman from Medurstand-Understanding Medicine, and I'm going to talk about common anemias today. You know, anemia is a very common condition and there are various causes. Some are common, some are rare, some are easily diagnosed in the outpatient department by reasonably trained family physician, and some would require specialized investigation and specialized treatment. So this lecture is about common anemias and the initial approach. So this would particularly emphasize the value of this CBC test, which is commonly done and is not given due importance, but it has got wealth of information if you examine it carefully. So compare these two. This is the CBC, which has got wealth of information, and this is as unimpressive and as unflattering as the invoice you receive from the grocery store. So don't go by the looks. It has got very useful information backed with history and physical examination. If you examine this perchi very carefully, you would actually, I think in majority, you would know the cause of anemia. So some introductory slides. It is a computerized slip generated by auto analyzer. Previously, we used to order blood complete examination, which included ESR, but this is called CBC. This is done by machine, by auto analyzer. And it gives you counts, like count of everything, RBC, platelet, WBC, and it also gives indices. And what is meant by indices, I'll explain in the later slides. And it also gives you morphologies, like if the cells are normal size, bigger than normal, smaller than normal, if they're filled with hemoglobin normally, or they have less hemoglobin, or things like that. And it should be interpreted along with the history, and it gives important clues to various hematological disorders. Some are literally diagnosed. You may still require one or two further tests for confirmation. In many situations, you could go ahead with the treatment because from the history you already have some idea what may be the cause of anemia, and if you see this investigation CBC, and if that supports also your clinical impression, I think further tests would be unnecessary. That will be sheer waste of money and waste of time and waste of resources. Terminology, RBC count, of course, self-explanatory. It is counted as millions per liter, and women have slightly less than men. Hemoglobin, and that is the chemical test. HB is measured as grams per deciliter. But these days, there's more and more trend toward hematocrit. Hemoglobin and hematocrit both measure the amount of HB packed in cells, but this is the packed cell volume. So this would actually measure the total volume of RBCs. And both correlate approximately 3 times hemoglobin is a hematocrit. But in some cases, there may be slight difference. So both actually gives you the same information. These 3 parameters are measured by the machine directly, and then these are calculated. There are formulae. I will not go into the details. They're very simple. Mean corpuscular volume. Since this is the volume, so a PCV divided by the number of RBCs would give you MCV. The machine will calculate it for you and will give you what is the average cell volume. And mean corpuscular hemoglobin, this is the average amount of hemoglobin in every cell. So the total hemoglobin, amount of hemoglobin or hematocrit divided by the number of cells will give you MCH. You don't have to do it yourself. Machine will do it for you. And mean corpuscular hemoglobin concentration, this actually measures the concentration of hemoglobin within a cell. You know, sometimes cell may have the same amount of hemoglobin as normal, but since it is bigger, it may have actually lesser concentration. And red cell distribution width, this is very important. this will give you the variation in red blood cells. Uh, Cells could be microcytic or normocytic or macrocytic, but red cell width would tell you actually the distribution within the cells. And I think next slides will explain it further. These are derived. There is a built-in computer in this autoanalyzer. From these three values, machine will calculate these and they will also be printed on the report. So, approach to the diagnosis of anemia is, first of all, we examine the HB and hematocrit. Of course, in anemia, you expect both to be low. If there is normal HB or normal hematocrit, that means there is no anemia. One deficiency would be acute blood loss. Patient may have lost severe amount of blood and his HB or hematocrit may still be normal for some time, because it is only after hemodilution that HB will drop. So then we concentrate on CBC morphology. This CBC report will give you MCV, MCH and MCHC. So you examine all three carefully and you make a judgment. I think mostly we go by MCV, so mean corpuscular volume. On that basis we make a diagnosis which category of anemia this patient might have. Now give you some example. Hypochromic microcytic. Hypochromia and microcytosis usually go together. That means cells are likely to be smaller in size and are likely to be less color. So that of course is commonest type of anemia, and the commonest cause of hypochromic microcytic anemia is iron deficiency. If you have chronic iron deficiency, you are likely to have hypochromic microcytic anemia. And the commonest cause of chronic iron deficiency may be actually poor iron intake, but more likely it is the chronic blood loss. Like in women, there is menorrhagia. In both gender, there may be GA blood loss due to hemorrhoids or due to chronic acid peptic disease. So there may be actually chronic blood loss responsible for iron deficiency. There may be additional nutritional deficiency also, and in some cases it may be primarily due to nutritional deficiency. In either case, the picture would be the same and the treatment would also be the same. Of course, we have to remove the cause also. Another cause of hypochromic microcytic anemia in our country is thalassemia. Now let me emphasize that thalassemia is not at all rare. It is definitely much less common than iron deficiency, but it is common. So I think by default, all patients with hypochromic microcytic anemia would be considered as cases of iron deficiency. But if iron deficiency is ruled out by appropriate test or on history iron deficiency looks very unlikely, then you would consider thalassemia. And then of course you would do the test. It is mandatory that you rule out iron deficiency anemia before you go for the investigation of thalassemia. Why? Because the common things happen commonly. Even in atypical cases, you need to rule out common condition first. Now, if picture is macrocytic, patient is already anemic and RBC morphology tells you that the picture is macrocytic, then we have two possibilities, either vitamin B12 deficiency or folic acid deficiency. Now, there are multiple causes of these deficiencies. Vitamin B12 deficiency can occur in chronic gastritis, in pernicious anemia, in some worm infestation, and folic acid deficiency can occur in patients who are on anti-folate drugs, and multiple causes actually. Both have multiple causes, but both may cause macrocytic picture. And if you have vitamin B12 deficiency, there may be some neurological complications also, but luckily this is not common these days. In cases of normochromic normocytic pictures, that means cells look normal in their sizes and they look normal in their color also. That means this is normochromic normocytic anemia. This might look from the nomenclature that this is less serious, but actually normochromic normocytic anemias are potentially more serious. There are many causes, but I'm going to highlight only two. One is aplastic anemia. In aplastic anemia, bone marrow is not working fine, so lesser number of RBCs are produced, but those that are produced, they look normal. So this is aplastic anemia. In aplastic anemia, you would have some abnormalities in CBC other than red blood cells, like in white blood cells and platelet also. That will give you the clue to the diagnosis. Another category where you may have normochromic normocytic anemia is hemolytic anemia. In hemolytic anemias, you may also have slightly macrocytic picture, but I think classically, especially in acute hemolytic anemias, there would be normochromic normocytic picture. So from this slide, I think you should have some idea that very careful inspection of this CBC report, computer generated unimpressed report, you can have reasonably good idea which category you are dealing with. So further workup will be very easy, and in some cases further workup may not be necessary. For example, in a woman with menorrhagia, if you have iron deficiency type of anemia, the pattern is hypochromic microcytic, I would rather go for the replacement of iron rather than going for that test. So this thing we are going to focus on these two more in this lecture. So this is my favorite concept, a three-step approach to the diagnosis of anemia. First of all, we'll examine this one, okay? Now, of course, in this case, it looks like normal, but in anemia, this would be low. And the second step would be to go for the indices. Out of these three, I think I would categorize anemia based on MCV. As I said earlier, MCV and MCH are mostly in the same direction. Both are likely to be low in these cases, but if there is some disparity, anemia should be classified according to MCV. And then finally the RDW. So if you have a case of microcytic hypochromic anemia, then RDW will help you to further differentiate between two conditions, as will be outlined in one of the next slides. So let's do some exercise. This is the CBC report, and this is the normal. I have given it here. So this one, HB normal, and these indices are normal. RDW is also normal. So this is actually normal CBC. This was for the reference, and now we do the exercise. Now let's do this exercise. This is our first case. Now, first of all, our first step is to look for hemoglobin and hematocrit. In this case, it is very obviously low. HB and hematocrit both are less than the reference ranges. So this patient has got anemia. So first, I think step is very easy. This patient has got anemia. And second step, we see the RBC indices. MCV is less than normal, 69.7 compared to 78, between 78 and 98. So this is low. This patient has got a microcytic picture. You know, MCV refers to the RBC size. So size is less than normal. So it would be called microcytic picture. MCH is also low. It's 22.6 compared to the normal range of 27 to 32. So this is also low. MCH refers to the average amount of hemoglobin in one cell. So it is hypochromic, right? So microcytic hypochromic picture we have already figured out. And then MCHC is within the normal range. So what do you think is the diagnosis? I think it should be very easy. Hypochromic microcytic anemia, and the commonest cause of such anemia would be iron deficiency. So iron deficiency anemia, iron deficiency could be due to poor iron intake or more commonly due to chronic blood loss. So you need to have proper history taken. History is very important. Physical examination may also be important. in addition to common signs of anemia, these patients may show chylonychia, which is actually a sign of chronic iron deficiency. In some cases, iron studies would be needed. And in one of the slides, I'll show you what are those studies. But in majority, I think if somebody has history of menorrhagia or history of chronic bleeding per rectum due to hemorrhoids or chronic gastritis or worm infestation, or you can judge from the history that the patient's food intake is inadequate, I don't really think that you need to go further for the test, because that will be waste of resources and the time. So this is very typical picture of chronic iron deficiency anemia. In these cases, if there is no history of obvious blood loss and patient's food intake also seems to be okay, then you need to investigate for possible blood loss from the gut, occult blood loss. So I think not always need. Second possibility, if you have a picture of hypochromic microcytic anemia, the second possibility is thalassemia. First of all, history would be important, and this thalassemia usually runs in the family. But surprisingly, sometimes the parents are diagnosed as case of thalassemia straight after the index case is diagnosed. Nothing to suggest iron deficiency, then you should suspect thalassemia, and there is family history of thalassemia. So these are two situations where you would suspect thalassemia as a cause of hypochromic microcytic anemia. So after you have done this, you come to the third level of CBC. I intentionally kept it till this level, RDW. So in both situations, if there is iron deficiency or there is thalassemia, in both situations, HB will be low, and both situations there will be hypochromic microcytic picture. But RDW will differentiate between the two. In thalassemia, all cells are uniformly hypochromic and uniformly microcytic. So the variation within the cells is minimal. RDW refers to the variation in cells, so it would increase RDW would indicate iron deficiency, because RBCs, whenever a particular RBC was produced, and depending upon the level of iron deficiency at that time, the microcytosis and hypochromia could vary. Okay, so this is why same picture but increased RDW would indicate iron deficiency anemia as compared to thalassemia. In thalassemia, this is likely to be very, very narrow, like 12 or similar figure. So this was the commonest, and then let's go further. If you need to investigate iron deficiency, these are the tests. Serum iron can be done, total iron binding capacity can be done, transferrin saturation will be done, and ferritin can be done. All have limitations. Iron has this limitation that it is possible that patient has started taking iron recently. So if you test iron, it might come out to be normal, but patient still has iron deficiency anemia. And TIBC is increased in iron deficiency anemia, but if patient has got additional nutritional deficiencies, malnutrition, then TIBC might not increase. If patient has got chronic diseases, then TIBC also might not increase. Ferritin is an acute phase reactant, so it is possible that patient actually has iron deficiency anemia but has got some recent stress, and due to stress ferritin level is elevated, so it might actually mislead you. So that's why in case you need to have the test, you have to have all of them to have good picture. If these tests do not indicate iron deficiency, then you have to go for tests of thalassemia, and the typical test is hemoglobin electrophoresis. And in some cases in alpha thalassemia, you might need to go for DNA test also, because electrophoresis is not abnormal in alpha thalassemia. Maybe in next slide I'll explain how. So this is I'm little bit about this hemoglobin electrophoresis. This is some facts we need to know. Normal hemoglobin is hemoglobin A, that is about 95 to 98% in adults. And this consists of 2 alpha chains and 2 beta chains. You see these 2 alpha chains and these 2 beta chains, this constitute about 98%, 95 to 98% hemoglobin. This is normal hemoglobin. But hemoglobin F is also normal. In adults, we have a very small percentage, up to 2% in adults is normal. But if it is more than that, that would indicate an abnormality. And this is 2 alpha chains and 2 gamma chains. And then we have hemoglobin A2. In hemoglobin A2, you have 2 alpha chains and you have 2 delta chains. Please note down all 3 normal hemoglobins have alpha chains. So alpha chain is indispensable. There is no hemoglobin molecule, a functioning hemoglobin molecule without alpha chain. But beta chain can be replaced by gamma or delta chain. So that will be hemoglobin F or hemoglobin A2. In thalassemias, because beta thalassemia, sorry, I'm going to talk about the beta thalassemia. In beta thalassemia, there is deficiency of beta chain. So if beta chains are deficient, then an alternate chain like gamma or delta will be made. So you will have increase in hemoglobin F or hemoglobin A2. That is the philosophy of hemoglobin electrophoresis. Now let me explain it in some more detail in the next slide. So this is alpha chain, and you have equivalent all 3 other chains, beta, gamma and delta together. We are talking about adults, right? We have as many alpha chains as we have beta, gamma and delta all together. So that will make our normal hemoglobin 95 to 98% A1 and 2 to 3% A2 and 0.8 to 2% hemoglobin F. So this is the electrophoresis. This would be the pattern. Hemoglobin F will be shown as a small spike. Hemoglobin A2 is another slightly bigger spike, and the hemoglobin A would make the biggest spike. So this is the typical report of hemoglobin electrophoresis. So this is normal. In beta thalassemia, how things change, I'm going to explain that. There is quantitative abnormality in beta chains. So beta chains are produced in lesser quantities. Okay, so beta chain is less. So this will become shorter. But you must have increase in gamma and delta to balance the alpha chain. So see, gamma and delta has increased. Gamma and delta has increased to fill the gap because alpha chain and all 3 other chains taken together must equal. So in this slide, in this electrophoresis, you have seen that hemoglobin F peak and hemoglobin A2 peak has grown in size, whereas hemoglobin A peak has become smaller. So if this is a picture, hemoglobin A2 has increased, hemoglobin F has increased, and hemoglobin A has reduced. So this will give you the picture of beta thalassemia. Now you must, I think, realize that this concept will be applicable only on beta thalassemia, because alpha chain is indispensable in alpha thalassemias. If alpha chain is reduced, it cannot be replaced by any alternate chain, so you will have no abnormality on electrophoresis. There is anemia, but the relative proportion of these different types of hemoglobins remains unchanged. For that, you would need to do DNA analysis for alpha chain. So this was mostly about hypochromic microcytic anemia. We have covered iron deficiency, and I've talked about the iron deficiency test also. And the second possibility in hypochromic microcytic anemia is thalassemia, and we talked about the principle behind hemoglobin electrophoresis. Now let's proceed with other types of common anemias. This is another case First step, HB is less than normal, hematocrit is less than normal, so this is a case of anemia. And the second step, MCV is more than normal. That means cells are bigger than normal. That means this patient has got macrocytosis. MCH is also increased. MCHC is reduced or within the lower normal range. So this is anemia which is macrocytic. Okay, so macrocytic anemia. What are the types? Vitamin B12 deficiency, fairly common. You know, vitamin B12 comes from the animal source. If somebody is strict vegetarian, he or she is likely to have vitamin B12 deficiency. Or people with some chronic stomach problem, gastritis, pernicious anemia, some worm infestation, there may be vitamin B12 deficiency. Folic acid deficiency would be another possibility. You can't actually differentiate between vitamin B12 deficiency or folic acid deficiency from the CBC. But both require, if you want to go for the test, then you would have to have vitamin B12 assay and folic acid assays. Otherwise, in real world, I think you could replace both of them. They are very cheap drugs, so you could replace both of them simultaneously and see how patient responds. History will provide important clues. So for patient's dietary habits, possibility of worm infestation, a patient is taking anti-folate drugs. There are many drugs, anti-rheumatic drugs, antimicrobial drugs, anti-epileptic drugs. There are many drugs which might have anti-folate activity. So I think you go into the history and that might give you the clue to the diagnosis. And chronic dyspepsia might also give you the clue to the diagnosis of chronic gastritis. Coming to the end, this is another picture. HB is low, hematocrit is low. So his patient has got anemia. But see all the indices. MCV is normal, MCH is normal, MCHC is normal. So this patient has got normochromic normocytic anemia. In this case, it would be mandatory to go to the WBC section also. See, total count is reduced. That points toward the bone marrow etiology. And polymorphs are also reduced, only 30%. They should be normally about 65-70%. Lymphocytes are increased. So polylympho ratio is actually reversed. Polylympho ratio is reversed in the background of reduced total count. So this would be suggestive of bone marrow depression. Why there is a reversal of polylympho ratio? Because in bone marrow depression, in aplastic anemia, polys or neutrophils are more affected because neutrophils are made only in the bone marrow, whereas lymphocytes are also made in the peripheral tissues like lymphatic tissue, spleen, other areas. So lymphocytes will remain normal and polys will be reduced, so the ratio will be reversed. And RBC count is also reduced. So this would typically point toward the aplastic anemia. And similarly, platelet count is also reduced. So in aplastic anemia, you actually have pancytopenia. All cell type, all 3 cell lines are reduced. You have a reduction in RBCs, you have a reduction in WBCs, and you have also a reduction in platelets. So that would be very suggestive of bone marrow depression, aplastic anemia. So normocytic, normochromic anemia, which is aplastic. There are other causes also, but this one is the aplastic picture. So if you are dealing with an aplastic anemia, it could be idiopathic, autoimmune, or it could be secondary. Now in the next slide, I'm going to explain this concept in some more detail, this reversal of polylympho with the graph, with some graphics. So if there is iron deficiency, you could, of course, you first have to remove and treat the cause. If somebody has worm infestation, you need to treat him for that. And you need to also adopt certain dietary measures. Patient need to be advised to take diet which has got ample iron. Best iron comes in the form of meat, which is heme. And although iron is present in vegetables and fruits also, but that is not a very good quality iron, and that's not absorbed fully. Oral iron ferrous sulfate is very good, but some people they have tolerability issue, some people have some adherence issue. Ferrous sulfate given once or twice a day with meal for 3 to 6 months would correct anemia of iron deficiency origin. But people have the compliance issue. So I think this injectable iron, ferric carboxy maltose, has, I think, solved this issue. This comes in 500 milligram in 10 ml preparation. It is to be mixed in normal saline, about 100 ml saline, and infused over half an hour. And one infusion can give you 2.5 gram of hemoglobin. So depending upon patient's HB, you could make a calculation 2 or 3 infusions of this ferric carboxy maltose will correct anemia. So this will be a solution for those who cannot tolerate oral iron or who are unable to adhere to long-term therapy. Treatment of macrocytic anemia, remove and treat the cause first of all, and then vitamin B12 supplementation. We have traditional vitamin B12 preparation that can be given orally, or we have active form of vitamin B12 in the form of methylcobalamin, so that can be given once a day for 3 to 6 months. Or in some cases you might like to replace vitamin B12 parenterally. People with pernicious anemia, they cannot absorb vitamin B12, so oral supplementation will not be effective. So you will have to give parenteral, either intravenously or intramuscularly. I think 10 injections of vitamin B12 over a period of 2 or 3 months will correct anemia. So if somebody has folic acid deficiency, you can replace folic acid by simple traditional folic acid tablet 5 milligram once a day for 3 to 6 months. But those patients who have some anti-folate drugs taking, for them I think active form of folic acid in the form of 5-methyl tetrahydrofolate may be better. So again, 1 tablet a day. This is also available in injection form, but mostly oral is sufficient. You might also like to explain to the patient to increase the intake of green leafy vegetables also. So this will correct the folic acid and vitamin B12 deficiency. If somebody has combined deficiency, you will have to give iron as well as folic acid and vitamin B12. So this is the summary of this presentation. A careful inspection of CBC gives you valuable information to the likely cause of anemia in majority. Combined with history, further tests may not be needed in majority. That will save time, money and resources. Next time you see this unimpressive report of CBC, please give it some respect and examine it carefully. It will give you a wealth of information, and in many cases it will give you the final diagnosis. Common anemias may be treated easily as outlined in this lecture. Thank you very much. This has been Professor Aziz Rehman from Medurstand-Understanding Medicine. Please follow me in my next lecture. I'm really looking forward to see you there also. Thank you, Professor Aziz Rehman.